All right, you guys, in this video, I'm going to be teaching you pretty much everything that you need to know for acid-base disorders. So let's just get right into it. So for acid-base disorders, we're obviously going to need to know what a normal range for pH should be. And that's going to be a pH of 7.35 to 7.45. If you're anywhere to the left of this, then you're going to be acidemic. And then if you're anywhere to the right of this, then you're going to be alkalemic. The way that we actually assess this in the hospital is that usually we will get a venous blood gas or an arterial blood gas, and that way we will be able to see what the pH is. One thing that will commonly come up is that a VBG is actually going to tend to be a little bit more acidemic than your arterial blood gas, and so a VBG that shows a pH of 7.20 would be roughly the equivalent of an ABG with a pH of 7.25. So basically you add a correction factor of 0.05 in order to get the accurate blood pH. And then the other two things that we're going to look at is we're going to look at the PCO2 or the carbon dioxide level, and we're also going to look at the bicarbonate level. One important thing about this is that the PCO2 we're going to be looking at from the VBG or the ABG, but the bicarb level, we really want to be using the bicarb that's listed on the basic metabolic panel. And the reason for this is that's an actual measured value and it's more accurate, whereas on the ABG and the VBG, it's kind of a calculated value. So the next step is really combining all of these together to really figure out what acid-base disorder is going on in your patient. So for example, if your patient is acidemic with a pH of 7.2, then there are two potential options here. So if their pH is 7.20 and they have a low PCO2 and a low bicarb, then that's going to be a metabolic acidosis. And on the other hand, if they have a pH of 7.2, but they have a high PCO2, which means they're retaining carbon dioxide, and a high bicarb, that's going to be a respiratory acidosis. On the other end of things, we can have a high pH with a high PCO2 and a high bicarb, and that's going to be a metabolic alkalosis. And we can also have a high pH with a low PCO2 and a low bicarb, and that's going to be a respiratory alkalosis. So let's start with the metabolic alkalosis, because this is the one that you're probably going to see the most often and is kind of the most relevant one and the one that you're most commonly going to get questions on as well. So metabolic acidosis. The two key categories here are that you're going to have a non-anion gap metabolic acidosis versus an anion gap metabolic acidosis. So how do you calculate an anion gap? First of all, say that the patient has a sodium of 140, a chloride of 100, and a bicarb of 20. Basically what you do is you take the sodium minus the chloride minus the bicarb, and that will get you the anion gap. So in this case, it'd be 140 minus 100 minus 20 equals an anion gap of 20. So any anion gap greater than 12 is considered an anion gap metabolic acidosis. One thing that you also sometimes have to do is that if a patient has really low albumin, you may have to correct for albumin. So say in another case, you have a patient with a sodium of 135, a chloride of 105, and a bicarb of 20, and an albumin of 2, then you're actually going to have to correct for this level of hypoalbuminemia. So you're going to get 135 minus 105 minus 20 equals anion gap of 10. But to correct for the level of hypoalbuminemia, you do a correction factor. So normal albumin is 4. So for every 1 unit of albumin that's less than 4, then you have to add an additional 2.5 to the anion gap. So in this case, you do 4 minus 2 times 2.5 equals 5. So you're going to add 5 to the anion gap. So you get 10 plus 5. And this patient would actually have an anion gap metabolic acidosis because their anion gap is 15. So for non-anion gap metabolic acidosis, the two most common causes here are going to be diarrhea or GI losses versus renal tubular acidosis. And how do you differentiate between these two? The way you do that is you're going to get a urine anion gap, and usually the history is going to be pretty telling as well. But if you have a positive urine anion gap, that suggests an RTA, and if you have a negative urine anion gap, that suggests that their non-anion gap metabolic acidosis is due to diarrhea. The way that you test the urine anion gap is that you need to get a couple of urine electrolytes. You need to get the urine sodium, the urine potassium, and the urine chloride. And just to touch real briefly on why a positive urine anion gap suggests RTA. So type 1 RTA happens when you can't secrete ammonium into your collecting duct in your nephrons. So this is a problem with ammonium. And chloride is basically a counter ion to ammonium. So if you have ammonium in your urine, then your urine chloride will be high. And if you don't have any urine ammonium, then your urine chloride will be low. So in this case, with a patient with an RTA, this patient's urine chloride is going to be low, right? And so the equation for urine anion gap is sodium plus potassium minus chloride. So obviously, if your chloride is low, then it's more likely that the positive thing is going to stay positive. And so you're going to get positive, which suggests no ammonium because you have the low chloride. And basically, that means you have a renal tubular acidosis. Let me know if that didn't make sense to you. Basically, chloride is a surrogate for urine ammonium. And so if your chloride is low, you're going to have a positive urine anion gap, and that's going to suggest renal tubular acidosis, and that you have a problem with secreting ammonium into your collecting duct. Now, moving on to anion gap metabolic acidosis. This is where a lot of the money is going to be, because this is going to be really commonly what we see inpatient. And the things that you need to know here are two things that you're most commonly going to get questioned on or pimped on. The first thing is, first of all, what are common causes of anion gap metabolic acidosis? And there's a couple of mnemonics for this that you really should know. So the first one that every one of us learns in medical school is going to be MUDPILES. So that's going to be methanol, uremia, DKA, propylene glycol, iron or isoniazid, lactic acidosis, ethylene glycol, and salicylates. But actually recently there has been a new mnemonic that's been proposed and is actually supposed to be a little bit more superior and accurate in terms of identifying causes of anion gap metabolic acidosis, and that's going to be the GOLDMARK mnemonic. And so that's going to stand for glycols, oxoprolinemia, which is kind of a byproduct of Tylenol, L-lactic acidosis, D-lactic acidosis, methanol, aspirin, renal failure, and ketoacidosis. The reason that GOLDMARK is a little bit considered superior is a couple of reasons. So first of all, it groups all the glycols here. One note about this is that a lot of medications come in glycol-containing solutions. For example, Ativan, diazepam, Osmolar, phenytoin, and barbiturates. So it's not just kind of when people are drinking antifreeze or anything like that anymore. Oxoprolinemia accounts for Tylenol toxicity that patients can get even when they're just taking therapeutic levels of Tylenol and not super therapeutic levels. L-lactic acidosis is the kind of lactic acidosis that we all really think about, but this also includes D-lactic acidosis, which really is kind of this problem with the gut biome and the gut microbiota. It involves lactic acidosis that's created from gut bacteria, basically. We also have methanol in both of them. Aspirin kind of takes over for salicylates here. Renal failure is kind of the uremia here. And then ketoacidosis is a little bit more broad than DKA, so it can also account for alcoholic ketoacidosis and starvation ketoacidosis rather than just DKA. So one additional thing that you want to do a lot of times for anion gap metabolic acidosis, especially if you don't have a clear indicator of what the etiology is that you want to calculate an osmolar gap. And basically the way that you do this is that you order a serum osmolality, and from this you subtract a calculated osmolality. Usually I just go on MD-Calc for this. You go to serum osmolality and osmolarity. Usually it's like something like 2 times the sodium plus BUN divided by 2.8 and glucose divided by 18 or something like that. But basically this will actually calculate the serum osmolality for you. And if the gap is greater than 10, then you have an additional unmeasured anion, which oftentimes suggests some kind of additional alcohol or something, or a glycol that's causing your lactic acidosis. So this is definitely something you should be aware of because it's useful to calculate, especially if you're thinking that like an ethylene glycol or propylene glycol poisoning is higher on your differential. So the next question that people are often going to ask you is, how do you calculate if the patient is actually compensating for their level of anion gap metabolic acidosis? And so the answer to that is going to be Winter's formula, which you are probably familiar with or have at least heard of before. And so basically we calculate this by seeing what the PCO2 is, because basically when these patients are acidemic, they're going to start breathing off some carbon dioxide in order to breathe off some of that excess H+ ion. And so the equation for Winter's formula is PCO2 equals 1.5 times the bicarb level plus 8 plus or minus 2. So for example, if a patient comes in with a pH of 7.2 and a bicarb of say 16, then what would their expected PCO2 be if they were compensating adequately from a respiratory standpoint? So that would be 1.5 times 16 plus 8 plus or minus 2. So that would be 24 plus 8 equals 32 plus or minus 2. So we would expect their PCO2 to be anywhere between 30 and 34. If instead, for example, we saw that their PCO2 was 40 or 45 or something, then that would suggest that there is an additional respiratory acidosis on top of their anion gap metabolic acidosis. The other thing that you're going to learn about really over and over again is going to be the delta-delta gap. And so why do we calculate delta-delta? This is to calculate if there is basically an additional acid-base disorder on top of the anion gap metabolic acidosis. So when we calculate this, we're trying to ask, is there an anion gap metabolic acidosis plus an additional non-anion gap metabolic acidosis, or plus an additional metabolic alkalosis? And this is really confusing and takes multiple repetitions to really understand how it works. But honestly, once it clicks for you, it's going to make a lot more sense. So basically, the reason it's called delta-delta is because it's the change in your anion gap over the change in your bicarb level. So if this ratio is less than 0.8, anion gap metabolic acidosis plus non-anion gap metabolic acidosis. And if it is greater than 2, then that suggests anion gap metabolic acidosis plus metabolic alkalosis. If it's between 0.8 and 2, then it's just anion gap metabolic acidosis alone. So how do we calculate this? So first, change in anion gap. Basically, your normal anion gap is 12, right? And then your normal bicarb is 24. So what we do is we take the patient's anion gap. So say the patient has an anion gap of 16. So you get 16 minus 12, and say their bicarb was 20. So that would be 24 minus 20. So then you get 4 over 4. So their delta-delta is a ratio of 1.0. So they have a pure anion gap metabolic acidosis. So let's do some additional examples so you guys get a better feel for how the delta-delta works. So for example, let's say a patient has a sodium of 135, a chloride of 100, and a bicarb of 15. So what is their anion gap? So anion gap is 20. So what is our delta-delta? So change in anion gap over change in bicarb. 20 minus 12 over 24 minus 15 equals 8 over 9. So this is a pure anion gap metabolic acidosis. Now let's change it around a little bit, and let's say a patient has sodium of 135, a chloride of 105, and a bicarb of 10. So anion gap in this case is still 20. So change in anion gap over change in bicarb equals 20 minus 12 over 24 minus 10. So this patient is going to have an equation that's 8 over 14, which is less than 0.8. So this patient has both anion gap metabolic acidosis plus a non-anion gap metabolic acidosis. Final example here. So patient has a sodium of 135, a chloride of 95, and a bicarb of 20. Again, anion gap is 20. So 20 minus 12 over 24 minus 20 equals 8 over 4. And that is a ratio of 2.0, which suggests anion gap metabolic acidosis plus an additional metabolic alkalosis. All right, so hopefully these examples help to illustrate how you actually calculate the anion gap and the delta-delta. And the delta-delta is a lot less complicated than, honestly, a lot of times it may seem when you learn it over and over. All right, so going back to our second topic, we're going to talk about respiratory acidosis next. So let's move on to that slide. So respiratory acidosis, I would say, is kind of the second most common acid-base disorder that you're going to see. You're going to see this a lot in like COPD patients or anybody with obstructive lung disease or who has any problems with ventilation. So for this, the main question that we usually ask is this acute respiratory acidosis or is this chronic respiratory acidosis? And there's a couple ways to determine this. The number one way is to look at their pH, okay? So for a patient, for example, who comes in with a pH of 7.16 and a PCO2 of 70, this is going to be acute respiratory acidosis. So think about a person who's having a severe asthma attack or COPD exacerbation, and they're really not ventilating well. Whereas somebody who has chronically had COPD and they're always hypercarbic, then they would have something that looks more like a pH of 7.31 and a PCO2 of 70, and that's going to be chronic. So the thing you look for with their pH is that in acute respiratory acidosis, you will tend to see a drop in pH of 0.08 for every increase in PCO2 by 10. So for this patient, a normal PCO2 is 40, right? So they have 30 more millimeters of mercury more pressure of PCO2. So we would expect a drop in their pH by 0.24. And so that's exactly what we see. So if a patient has a normal pH of 7.40 minus 0.24, we get 7.16. On the other hand, with chronic respiratory acidosis, you're only going to see a pH drop of 0.03 for every 10 increase in your PCO2. So in this case, patient again has 30 millimeters of mercury increased PCO2, but this is chronic, so the body has had time to compensate for this. So we only see a drop in the pH of 0.09. So that's what we see with this patient getting their pH of 7.31. The other thing that you can look at is their bicarb level, because as they have more respiratory acidosis, if there is adequate compensation, their bicarb level should start to increase over time in order to compensate for that. So in this case, for acute respiratory acidosis, you're only going to see a 1 milligram per deciliter increase in the bicarb for every 10 PCO2. Whereas for chronic, you're actually going to have a 3.5 milligram per deciliter increase in the bicarb for every 10 PCO2 above normal. So for example, in this patient, they will have a 7.16 pH, PCO2 of 70, and a bicarb of 27, because the normal bicarb is 24, right? So you're increased by 27. But in a chronic respiratory acidotic patient, it's going to be 7.31 with a PCO2 of 70 and a bicarb of 3.5 times 3, which is 10.5. So 24 plus 10.5. So they should have a bicarb level of 34.5. Now let's talk briefly about the alkalotic syndromes and alkalotic problems. So basically these are going to be a lot shorter than other ones. So metabolic alkalosis and respiratory alkalosis. Not too much to say on these ones. These are far less common, at least in my experience, for you to be dealing with or evaluating while they're inpatient. But for metabolic alkalosis, basically you're trying to determine, is this chloride responsive or chlorine resistant? So the test you want to get is the urine chloride. And if the urine chloride is greater than 15, then that means you are chloride resistant. And if urine chloride is less than 15, then you're chloride responsive or saline responsive. So chloride resistant etiologies are often like conditions like hyperaldosteronism, Conan syndrome. So these patients don't actually have a volume problem, and they're not going to respond to you giving them normal saline or fluids. Whereas chloride responsive patients, usually they had volume depletion, usually from GI losses or diuretics. And so they actually will respond to a fluid bolus in terms of correcting their metabolic alkalosis. For respiratory alkalosis, there's not much to know here. The most common causes are going to be anything that's causing tachypnea. You may see this in asthmatic patients before they start having kind of more of a respiratory acidosis picture. So acute versus chronic respiratory alkalosis. Basically, the way that you can calculate this is HCO3 will decrease by 2 for every 10 decrease in the PCO2. And for chronic, you have a little bit more time. So the bicarb will decrease by 5 for every 10 decrease in the PCO2. This is an acid-base disorder compensation chart that you can really easily Google on Google Images, and I really liked referring to just for a quick refresher. So obviously, again, for metabolic acidosis, we're going to be looking at Winter's formula. For metabolic alkalosis, this is what we're going to see in terms of the change in the PCO2 in response to the metabolic alkalosis. For respiratory acidosis, this is obviously, these are kind of the main important ones to look at. But for acute versus chronic respiratory acidosis, the big ones are acute is going to drop your pH a lot more than chronic. And then finally, for respiratory alkalosis, these are kind of the equations that I talked to you guys about earlier. And that's pretty much it. Those are all the high yield things. Hopefully this was helpful for you. I know that for me, it was very difficult going through delta for a long time, really didn't understand that. And a lot of these topics, you'll need a lot of repetition for it to finally start to click. And hopefully this video will help you with retaining some of that information. Please let me know if you have any questions down in the comments down below. I'd love to help answer them. Or if you have any other tips or tricks that you think would be useful for people. Really appreciate you watching. I hope you tune in for the next video. And thanks again for watching. I'll see you in the next one. Peace.